In this section, we will look into a group of diseases called myopathies. The primary diseases of skeletal muscle may be classified as follows: inherited myopathies, such as Duchenne and Becker muscular dystrophy; inflammatory myopathies, such as dermatomyositis, polymyositis, and inclusion body myositis; and toxic myopathies induced by either drugs, thyrotoxicosis, or alcohol. Muscular dystrophies include many inherited disorders of skeletal muscle that have progressive muscular damage. With the exception of congenital muscular dystrophies, these diseases do not present in infancy. They are characterized by progressive muscle weakness and wasting, and muscle from these patients show necrosis, regeneration, progressive fibrosis, and infiltration by fatty tissue. The main types of muscular dystrophies include X-linked muscular dystrophies, such as Duchenne muscular dystrophy and Becker muscular dystrophy. You also have autosomal muscular dystrophy and myotonic dystrophy. Duchenne muscular dystrophy is a severe progressive X-linked disease. It was first described by Guillaume Benjamin Armand Duchenne, a French neurologist in the 1860s. It is caused by mutations of dystrophin gene on the short arm of X chromosome. The encoded protein dystrophin is located in the inner sarcolemma surface. This complex spans the plasma membrane and link between the cytoskeleton, which is located in the inner sarcolemma surface, with the basement membrane outside of the cell. Duchenne muscular dystrophy is characterized by progressive degeneration of muscles, particularly those of the pelvic and shoulder girdles. It is the most common non-inflammatory myopathy in children, and serum creatine kinase is usually greatly increased in these conditions. This diagram shows the protein linking dystrophin to the plasma membrane and the contractile apparatus. So this is the contractile apparatus, this is actin, and this is dystrophin, which links the contractile apparatus to the plasma membrane. So dystrophin is an important element for the integrity of the muscle because they are responsible for connecting the cytoskeleton of each muscle fiber to the underlying basal lamina layer. This is the basal lamina layer. So these provide mechanical stability to the myofiber and the cell membrane during muscle contraction. Without dystrophin, the muscle fiber are liable to tearing due to repetitive contraction. So this is a picture showing the presence of dystrophin, and here there is lack of dystrophin. So due to the absence of the dystrophin, when there is repetitive contraction, the muscle fibers are liable to tearing, such as this one. There's sarcolemmal damage when there is absence of dystrophin. So the loss of dystrophin causes destabilization of the skeletal muscle cell plasma membrane that permits calcium influx, and that could lead to cellular necrosis with the activation of all the calcium-dependent enzymes. Creatine kinase increase because of the muscle necrosis, and this leads to degeneration with attempt of regeneration. As a person grows older, there is less regeneration, so they become weaker, and there is replacement of the muscle fibers by fibrosis and fatty tissue. Duchenne muscular dystrophy is typically associated with deletions or frameshift mutation that results in total absence of dystrophin. Compare this to the mutations in Becker muscular dystrophy, which retains some function of dystrophin because there is synthesis of truncated version of dystrophin. Because Duchenne muscular dystrophy is inherited as an X-linked recessive disease, the abnormal gene is passed from heterozygous carrier mothers. However, about 30% of cases are due to spontaneous somatic mutation. Morphologically, Duchenne muscular dystrophy will show necrosis of the muscle fibers, continuous effort at repair and regeneration, and as the disease progresses, the muscle tissue is replaced by fibrofatty tissue. And this you can see here in this picture, there is variation of size. So you can see atrophy of the muscle, and you can also see regenerating myofibers, which shows the bluish color. And there is also endomysial fibrosis around the muscle fibers. Immunohistochemical study will show the absence of dystrophin. Is a membrane-associated dystrophin. This is the color of a normal dystrophin-containing muscle fibers. And you can see here there's lack of the dystrophin fibers. And in the last biopsy, you can see there's replacement of the muscle fibers with fat and fibrosis. The muscle weakness is not detectable during the first year, and the patient appear normal at birth. By the age of 3 or 4 years old, there is muscle weakness at the proximal muscles involving the pelvis and the shoulder girdles. So the patients will have difficulty in running and rising to his feet. There's pseudohypertrophy or enlargement of the muscle when the muscle fibers are replaced by fibroadipose tissue. And patients are usually wheelchair bound by the age of 10 and bedridden by the age of 15. Death is usually from complications of respiratory insufficiency because of muscle weakness of the diaphragm or the respiratory muscles, or cardiac arrhythmia because of myocardial involvement. And dystrophin is also expressed in the heart and the CNS. Other extraskeletal manifestations include gastrointestinal dysfunction and mental retardation. Diagnosis is often on clinical suspicion. There is usually Gowers sign that is positive, so the patient must use his hands to climb up his legs. Blood test shows elevated creatine kinase, and biopsy shows variation in muscle fiber size, necrosis, regeneration, and replacement by fibrofatty tissue. Immunofluorescence staining shows absence of dystrophin. Now we look at Becker muscular dystrophy, which is also an X-linked recessive disorder and is also due to mutation in the dystrophin gene. It also results in progressive muscle degeneration and proximal muscle weakness, but this condition is less common and less severe than Duchenne muscular dystrophy. It is because in patients with this disease are able to synthesize at least some dystrophin, sometimes in its truncated form. It has a later onset compared to Duchenne muscular dystrophy, and it is a less severe form. Yeah? Most patients survive into adulthood. Despite modern advances in gene therapy and molecular biology, muscular dystrophies remains incurable. Passive physiology helps prevent contractures in the later stages, and portable respiratory support improves life expectancy. Carriers have increased chance of having children with Duchenne or Becker, so if a woman knows she is a carrier, she can make a more informed childbearing plans. Females with an affected brother have 50% chance of carrying the gene, and carrier and prenatal diagnoses are available with genetic counseling. Now we go to inflammatory myopathies, which are divided into infectious inflammatory myopathies, non-infectious inflammatory myopathies, and systemic inflammatory diseases. We will look into the first two, infectious inflammatory myopathies and non-infectious inflammatory myopathies, and we'll look into dermatomyositis, polymyositis, and inclusion body myositis. Infectious myositis may be caused by a broad range of bacterial, fungal, parasitic, and viral agents. Cysticercosis is a parasitic tissue infection caused by larval cysts of the tapeworm Taenia solium, which can affect the muscle. Pyomyositis and rhabdomyolysis are complications of myositis commonly seen in patients with diabetes and HIV infection. Now we look at non-infectious inflammatory myopathies. We look into dermatomyositis, polymyositis, and inclusion body myositis. Inflammatory myopathies are thought to have an autoimmune origin because they are seen with other autoimmune and connective tissue diseases. The pathology suggests autoimmune muscle cell injury, and serum autoantibodies can be detected. Polymyositis and dermatomyositis respond to immunosuppressive treatment. The morphologic characteristics include the presence of inflammatory cells, necrosis and phagocytosis of muscle fibers, mixture of regenerating and atrophic fibers, and fibrosis. Dermatomyositis is an immunologic disease in which damage to small blood vessels contributes to muscle injury. It is an inflammatory disorder of the skin as well as skeletal muscle. It is characterized by classic rash that accompany muscle disease and Gottron papules. The muscle weakness has a slow onset and is associated with autoantibodies. This is a feature of dermatomyositis. There is reddish purple eruption on the upper eyelid. This is called heliotrope rash and accompanied by swelling of the eyelid. And this is Gottron's papules. It can occur over the knuckles like this one. Muscle weakness is slow in onset in dermatomyositis, symmetric and often accompanied by myalgias. It typically affects the proximal muscles first. So as a result, getting up from a chair and climbing steps become increasingly difficult. Fine movements controlled by distal muscles are affected only late in the disease. Dysphagia, interstitial lung disease, and cardiac involvement can occur in dermatomyositis. You can see the inflammatory cells that are infiltrating the perimysium, and the periphery of the muscle fascicles show atrophy and damage. Polymyositis is an adult-onset inflammatory myopathy that shares myalgia and weakness with dermatomyositis, but lacks its distinctive cutaneous features. It has symmetric proximal muscle involvement and occurs mainly in adults. It is caused by cell-mediated injury of myocytes, probably due to CD8 cytotoxic T cells and macrophages. This picture, A, shows mononuclear inflammatory cells infiltrating the muscle, the endomysium. And you can see in B, there's necrosis of the muscle fibers and regenerating fibers with inflammatory cells. Inclusion body myositis is a disease of late adulthood that typically affects patients older than 50 and is the most common inflammatory myopathy in patients older than 65. Most affected individuals show slow progressive muscle weakness in the quadriceps and distal upper extremity muscles. Dysphagia can also occur in these patients. The features of inclusion body myositis resemble those of polymyositis, but there is a vacuole that is present. You can see the vacuoles in this stain. Acute alcoholic myopathy can be induced by bouts of heavy drinking, and that can cause acute muscle fiber necrosis, which can release myoglobin from the damaged fibers, and that can lead to acute renal failure. Subacute alcoholic myopathy occurs in chronic alcoholics and presents with proximal muscle weakness and wasting. There are drug-induced myopathy. Steroids can cause proximal myopathy. Lithium can cause muscle weakness, and fibrates can cause painful muscle. Most respond to drug withdrawal. Now we look at drug-induced myopathies. Proximal muscle weakness and atrophy can occur as a result of effect of steroid on muscle, whether in Cushing syndrome or during therapeutic administration of steroids. It is characterized by muscle fiber atrophy, predominantly affecting type 2 fibers. Chloroquine myopathy can occur after administration of chloroquine and hydroxychloroquine. These drugs interfere with normal lysosomal function and can cause a drug-induced lysosomal storage myopathy that presents with slowly progressive muscle weakness. The muscle shows myopathic changes including vacuolation that predominantly affects type 1 fibers. Statins are cholesterol-lowering drugs that are used widely to reduce the risk of acute ischemic cardiac events and stroke, and myopathy is the most common complication of statins. Thyroid dysfunction, whether hyperthyroidism or hypothyroidism, can lead to myopathy. Thyrotoxic myopathy presents as proximal muscle weakness that may precede other signs of hyperthyroidism. Hypothyroidism can cause cramping or aching of muscles and decreased movement.